Vanakkam. The practice of hand surgery is very different in very many ways from other surgical specialties. And just doing a surgery on the hand is not hand surgery. It's much more. I have learned small things that go into making hand surgery over the years, and I thought I would share with you the lessons I have learned in this journey of learning hand surgery. As I began my journey of learning hand surgery, one of the first few things I learned was that hand surgery was not just doing a surgery on the hand. It wasn't even doing versatile and complicated surgery on the hand. And it definitely was not just getting good results after a surgery on the hand. It was much more. So what are all the other things that make up hand surgery? A lot of things like follow-up, dealing with failures, documentation, teaching, surgical technique, developing a team, preparation, clinical examination, self-analysis, decision making. Let us consider all these one by one and what we need to learn and what I have learned in each of these. As always, clinical examination is paramount, and as far as hand surgery is concerned, there are a certain few unique points that I have learned in the course of my journey. The first important thing is to make the patient comfortable before examination. Every patient is different. We need to be empathetic, as always, and avoid painful examinations wherever possible. It is very important to get the confidence of the patient so that he is able to tell you exactly what his problems are. And this is very important to plan a customized protocol of management for that particular patient. It is easy to make a plan for a straightforward problem, but when the problem is complicated like this one, what do? There seem to be so many problems. So where do we start actually in planning the reconstruction? I have learned to use what I call the S3M2R concept. S1 consisting of skin problems. It could be ulcers, it could be atrophic scars, it could be contractures. These must be examined first, and when planning the management, these problems should be addressed first before any of the other problems. The second S that we need to examine is the skeleton. Any deformities caused by malunion, non-union must be examined and corrected after durable and supple skin cover has been provided. And before getting the hand reanimated, we need to get back sensation, the S3. Now we are ready to reanimate or get back movements. The first thing to get back is passive range of movements. That is, we need to correct the joint problems and the stiffness if there is any, and then plan for getting back the active range of movements with tendon transfers or tendon grafting. And in this protocol, R is the rehabilitation, which comes in before and after every single step that is followed. For example, in this particular patient, the first problem to be considered is S1, that is, he has an adherent scar with a grafted skin. So the first plan would be to resurface with flap cover before planning for any other reconstruction. After the clinical examination is complete, we would have seen the big problem. We need to analyze this problem and break it down into smaller problems. Now it would be easy to take small steps to correct the small problems that ultimately address the bigger, complete problem. Planning the sequence of steps is also equally important, which can be done according to the S3M2R concept. We can also classify according to whether the particular procedure that is planned requires post-operative immobilization or post-operative mobilization. So if a procedure requires post-operative immobilization, we cannot combine it with a procedure that requires post-operative mobilization. This patient sustained multiple level extensor tendon injuries at the level of the wrist and forearm, along with the fracture of the lower end of the radius on the left hand, and on the right hand he had an injury to the radial nerve at the level of the arm. So I learned to write down the problems in each hand and then write the plan for each of the problems that I had seen. Before we offer the options of management to the patient, we need to make a decision based on the clinical examination and the investigations that we have ordered. This decision-making process is another unique feature of hand surgery. We need to talk and explain in clear and understandable words both to the patient and the attender so that they can actively take part in the decision making. In some conditions, like amputations of the fingers, the decision needs to be made whether to replant or not. If the amputated parts have been crushed like this, the decision making is easy. It is not possible to replant these fingers. But in situations like amputation of a finger or thumb, avulsion amputations of the hand, or partial amputations of the finger, the decision making may be a little difficult. But I have learned that attempting the replantation or revascularization will definitely be rewarding. So whenever we come across a difficult situation of whether to replant an amputated part or not, I think the best principle to follow is the Nike principle: just do it. In hand surgery, it is always ideal to develop a good team. This will consist of your assistant, the anesthetist, the nurse who is assisting, the resident, the physiotherapist, and even the theatre assistant. And when preparing the team, we need to remember that every single member is an important and integral part of the team. So we need to keep them involved and their morale high. Of course, keeping in mind that discipline is of utmost importance. We need to assign a responsibility to each team member so that the entire procedure is a coordinated effort which will prove successful in the long run. Sometimes the hand surgery procedure may be prolonged. The primary surgeon may be involved and concentrating on his work, but the other members of the team may lose interest with time. I have learned that they need to be kept engaged also. This can be done by discussing the findings during the surgery, asking relevant questions from time to time. Having a muted background music will also help. But whatever we do, at no point should we compromise the concentration on the surgery aspect. While repairing the cut tendons and nerves in an injury like this, I ask the theatre assistant to put up a paper on the wall and keep noting down the points as I tell them. This keeps them involved and interested. Whatever the hand surgery procedure that is being planned, whether simple or complicated, we need to make adequate preparation before it is done. This can be done by what I have learned as the 4-point technique. The first point is learning the anatomy, the surgery, and more importantly the biomechanics from standard books. Armed with this basic knowledge, we can watch videos on YouTube and other websites to add on to what we have learned from the textbooks. After all these preparations, discussing with our teachers, colleagues and friends would go a long way in giving us a better understanding of the problem. The final preparation would be charting out exactly what we are planning to do. Like in this example of a partial amputation of the thumb, where I have charted out the entire procedure step by step. This process completed the preparation. Having done all the preparation, it is now the surgical technique that we need to concentrate on. And this will consist of not just the surgery per se, but the technique of giving regional blocks for minor hand surgery procedures, understanding the importance and the role of debridement, the place for new procedures, that is the indications, the importance of dressings, the technique of POP application, and finally the importance of therapy, which is very much an integral part of the entire procedure. After giving an axillary block, when we ask the patient to raise the upper limb, the hand falls. This would indicate motor blockade, and I call it the salute sign, where it looks like as if the patient is saluting you. I was under the impression that debridement is one of the steps in trauma surgery and reconstruction. But I slowly came to understand that debridement is the first and most important step before any reconstruction is done. In fact, I would call the debridement procedure as the basement for all reconstruction that is going to be performed. I have learned that it is always safe to follow standard procedures for reconstruction, but there may be situations where new procedures will be required, either to improve on results or in certain situations where the standard procedures cannot be done. For example, in this patient with a soft tissue defect on the thumb and the index finger, the thumb would require neurovascular island flap from the middle finger, but that would preclude a cross finger flap for the index finger. So I planned for a Littler's flap or the neurovascular island flap from the middle finger for the thumb and a homodigital island flap for the index finger defect. So an unconventional flap for a difficult situation, or as in this example with an amputation of thumb at the level of the proximal phalanx. To provide length, stability with bone and sensation, a conventional osteoplastic reconstruction could be done, but it is a staged procedure. So we have thought of a single stage osteoplastic reconstruction with an ulnar bone graft, a Littler's neurovascular island flap to provide sensation on the volar aspect, and a first dorsal metacarpal artery flap to provide a durable skin cover on the dorsal aspect. A new indication to improve the standard of non-microsurgical conventional reconstruction. So this could be an option for patients who refuse a toe transfer. After a very long and complicated surgery, the immobilization is very important. I have learned to apply the POP in two steps. The first step would consist of positioning the POP in the correct position, allowing the POP to set completely before the final dressing. This makes it neat and also ensures that the POP position is perfect. I have also come to learn that whatever the procedure on the hand that you do, however perfectly you do it, there is going to be no return of function without a proper therapy. Therapy must consist of the yin and the yang, the immobilization and the mobilization. In the early stages after surgery, it is immobilization that has more importance generally, and as healing progresses, immobilization and mobilization need to be alternated equally, and it is mobilization that predominates in the later stages. There is another part to hand surgery that is difficult to shrug off: failure and dealing with failure. After all, you do not learn anything by doing everything right. I have learned that there are three types of failures. The first type of a failure is where there is a loss of tissue or function, but it will heal with alternate minor procedures or just dressings alone. So even though there is a loss, the net loss is minimal. For example, in this patient for whom a groin flap has been done, there was a little bit of necrosis after flap division, but it healed with dressings alone. There are some failures where the loss of tissue or function will require an alternate major procedure for reconstruction. So the net loss is moderate. For example, in this patient who had an amputation of part of the left hand. A replantation was done, but it failed. So this had to be reconstructed with a groin flap. The third and most significant type of failure is loss of tissue or function in the primary area and the secondary area, and no simple alternate procedure is possible to reconstruct the failure that has occurred. The net loss is maximal. As in this patient, in whom a double toe transfer for reconstruction of fingers has failed. So the resultant defect is not only on the hand, but it is also on the foot. The possibility of failure should have been explained to the patient and the attender during the pre-surgical counseling. But after a failure occurs, we need to deal with our patient, the caregivers of the patient, our boss, our colleague, our student who has been watching, and our team members. Failure is a part and parcel of surgery, but failure is success if we learn from it. The result that you see on the table just as you are finishing the surgery is not the final result. A good follow-up is absolutely essential to see the results. The long-term follow-up may yield pleasant surprises or utter shocks. We may have a documentation of the surgery till the dressing is being applied, but we need to motivate the patients to come for review, and if they are not coming for review, we need to call them back. And when they do come for review, we need to treat them well, because we may need to follow up again. This young man, who had sustained a road traffic accident, had a fracture of the humerus with a complete transection of the radial nerve and multiple fractures of both forearm bones. He also had acute compartment syndrome involving the right forearm and hand. A rush nail stabilization of the fractured humerus was done, along with primary repair of the radial nerve. A fasciotomy was done on the right forearm, followed up with a skin graft after 3 days. The fractured forearm bones were conservatively managed with a POP alone. The patient was subsequently lost to follow-up. When I called him back again, he had a good healing of all the wounds and complete return of function of the radial nerve. All the fractures had healed well, and the return of function was also satisfactory. Similarly, nerve surgery also requires a long-term follow-up like brachial plexus surgery. In this patient who has had a loss of shoulder abduction and external rotation, you can see the timeline and how much time it takes for the complete recovery to occur. When a free functional muscle transfer is being done for getting back finger flexion in Folkman's contracture, the results can be seen provided we wait for a minimum of 8 to 12 months. But as I said earlier, results may not always be encouraging. This was only a skin laceration, a burst injury of course, in which the index finger was amputated, but the skin suturing was done and it looked all good. But when the patient came back after 3 months, this was the finding: a total contracture of the skin and the entire finger. We need to be very alert, predict problems, and take preventive steps in hand surgery, however small the case. Nowhere is documentation so important as in plastic surgery and hand surgery. This documentation consists of writing notes in the outpatient department, in the theatre and in the follow-up, in photography, cataloging, and accessibility of retrieving the documents. Using the standard and correct nomenclature for describing the problem in the hand is very important during documentation. Recording all the details is equally important. Photography plays a very important role, but they must be standardized. A uniform background for all pictures and standard views, volar, dorsal and radial view when the thumb is involved, and pictures should always be taken from the ulnar side. The lighting must be with flash with no other powerful lights. This will ensure a standard pre-op and post-op pictures. Videographic records are important for documenting movements and surgical steps. All the documentation that we have spoken about are also important from the medico-legal angle. Documentation is of no use if they are not catalogued properly in such a way that easy retrieval of information is possible. With all the documentation that you have done, you can always do a self-analysis to see whether what you have done is right or wrong and how it can be improved upon. So obviously, to analyze your performance, your statistics and records are very important. And you need to be critical about your self-analysis. If possible, you can also discuss your results with your peers. All these will help make the necessary changes for improvement. Just to show you how I did an analysis of cases done over 1 year in 2008, and the analysis was done in regard to form and function. I shall be showing you a sample of the analysis done for flaps and tendon surgery. Analyzing this patient for whom I have done a cross finger flap, I studied the results in terms of form and function, giving an arbitrary score of 100 for form and 100 for function. Because of loss of IP joint movements, I subtracted 40 from functional result and I subtracted 60 points for color mismatch, for texture mismatch and donor side scar. The end score was 60% for function and 40% for form. So we need to work towards improving form and function during the reconstruction of such defects. Analyzing the results of repair of flexor tendon injury in zone 4, -20 for restriction of finger movements, -30 for loss of little finger movement and -20 for extension deformity of the little finger and -20 for scars on the palm. This gave an overall result of 50% return of function and 60% return in form. Is teaching really a part of learning hand surgery? Yes, it is, because in learning you will teach and in teaching you will learn. When we start teaching, there will be a recruitment of memory and we need to prepare before the teaching. It helps us to put our thoughts and ideas in perspective. But whom do we teach? We can teach our students, our junior colleagues, our residents, the nurses who are assisting us, and even the theatre assistants. And this teaching need not necessarily be only in the classrooms. It can be in the outpatient department, in the operation theatre, in the dressing theatre, and even during the follow-up of the patient. It need not be just clinical case discussions and lectures. It could be a running commentary on the surgery being done, or by asking questions to impart information. It could be online teaching like on YouTube, and it could also be to provide skills with hands-on training. Whether it's a tooth forceps or a non-tooth forceps, make sure you do not injure the tendon by applying undue pressure. After that exciting journey in learning hand surgery, I have learned that I still have a lot more to learn. And it is important to never stop dreaming, never stop believing, never give up and never stop trying. And most importantly, never stop learning. I hope you enjoyed the video. I enjoyed making it. Please click on the shown links to see more about procedures in hand surgery and also the ethical practice of hand surgery. And do not forget to subscribe to stay connected with the latest in learning hand surgery, plastic surgery, trauma surgery and ethics. Vanakkam.